Welcome, everyone, to VACEP Presents, our online training series from the Virginia College of Emergency Physicians. My name is Jeff Kelly, and I manage communications for Virginia ACEP. Today, we bring you EMTALA and transfers, one of the most challenging and often misunderstood aspects of emergency medicine. Every ER doctor has faced a moment where a critically ill patient in front of you requires a specialty that you don't have on call, or a transfer center telling you that the hospital has no beds. But at the same time, EMTALA leaves little room for interpretation. Patients must receive a screening exam, be stabilized, and if you can't, they must be safely transferred to one that can. So, how do you navigate the tension while keeping patient care front and center? To answer that, I'm joined by two of Virginia's most experienced emergency medicine leaders who have spent years on the front lines of both patient care and hospital transfer policy. First up, Dr. Bruce Lowe, Chief of the Department of Emergency Medicine at Sentara Norfolk General Hospital, the Medical Director of the Sentara Transfer Center, and a Professor and Assistant Program Director at EVMS. He's also a past president of the Virginia College of Emergency Physicians, as well as Todd Parker, Associate Vice President and Executive Medical Director of the Riverside Integrated Care Command Center and the immediate past president of the Virginia College of Emergency Physicians. So let's turn it over to Dr. Lowe to walk us through, first of all, this federal law and its impact on transfers. Dr. Lowe.
Great. Well, thank you, Jeff, for that wonderful opening. I want to go ahead and share my screen here and talk about EMTALA and specifically around transfers. So yeah, I know everybody knows this, but just to make sure we're all on the same page, EMTALA is a federal law. It came out in 1986, and really it has just a couple of primary focus. The first thing is an MSC, or a medical screening examination, has to be performed when a patient presents to a hospital or to an emergency department seeking help. And this is regardless of their ability to pay, their insurance status, or what they're there for. And the reason why we do the MSC, or the medical screening exam, is to look for something called an EMC, an emergency medical condition. Now, if an EMC exists, then EMTALA goes into play. Basically, the EMC continues, or the EMTALA obligation continue until that EMC is either resolved or stabilized. And we'll kind of talk a little bit later on what stabilization means from an EMTALA perspective, because it's different from a clinical perspective. If a facility who has the patient who has identified an EMC is unable to resolve the EMC, then that patient must be transferred to a facility that can. Now, on the receiving side for a hospital, it's always important to understand that if you get a call for a transfer and that EMC exists and that sending facility can't handle it, if you have capability and capacity, then you must accept that transfer. And I think we also know this too, the legal obligation for EMTALA is really any patient who comes to the emergency department requesting help. And this actually extends up to 250 yards around the hospital. So not just the property itself, but the property or the area surrounding the hospital also.
And I think it's important. I think it's important there, Bruce, to recognize, that you don't have to have a perimeter of guards, that are guarding this 250-yard perimeter, but this is a regulatory requirement, so it just means that the obligations of EMTALA apply to any patient who is requesting to be evaluated for a possible emergency medical condition.
Great, that's a good point. Of course, EMTALA is a federal statute, and so violation of EMTALA has consequences, and specifically there could be up to monetary fines over $100,000 per event, as well as other penalties, including getting kicked out of participating with Medicare. And then if there are violations, especially if there's a bad outcome, that can be the basis for potential civil action in regards to EMTALA. So a lot of kind of at risk if you're in violation. So it's one of those things where we all need to make sure that we're compliant with federal law.
I think an important point with that, Bruce, is, so EMTALA is a civil action, but there are adjacent components of EMTALA. So when someone files an EMTALA complaint, there's also a section on there where they can indicate whether they believe their civil rights have been violated. And if they do, then you can file a civil rights violation complaint along with the EMTALA violation. So in other words, if someone believes that the EMTALA violation happened because they are a member of a protected class and received unfair treatment because of that. People sometimes think that EMTALA is a medical legal statute, and it's not. But what we are seeing is that there's a lot of overlap these days, and attorneys, plaintiffs' attorneys, are often filing EMTALA violations along with or in preparation for a medical legal complaint. So they may go hand in hand.
Yeah, and I think you bring up a good point, Todd, in the sense that even though it's a fairly narrow statute in terms of what it involves, if they come and do an investigation, it does kind of open you up to other possible investigation for other laws or statutes and things that you could be in violation of. So it opens the doorway for not just EMTALA, but for other things like civil discrimination and other potential issues that they could find as they kind of go through your charts. And speaking of which, as of last year, CMS has actually made it a lot easier for anybody to file an EMTALA complaint. So if you go to the website and the web address is listed below on the screen that you see there, anybody can file an EMTALA complaint fairly easily, and you can also file it anonymously. So they really lowered the bar in terms of being able to file the EMTALA complaint. And so the good news is, if you have concerns and you think that, man, somebody really violated, especially multiple times, it's not hard to file a complaint. The downside is it's easy to file a complaint. And so what we're seeing is a lot more complaints being filed, a lot more investigations. A lot of them, unfortunately, don't have merit. And so there is a whole investigative process and time and resource to go into it. But it is there not only for physicians or for administrators to file, but also for patients or patients' family if they feel like there is a potential violation.
And I've seen where I know in 2024 the number of EMTALA violations increased that were filed increased twofold over the previous year, and I've seen that that has increased again by another factor this year as they revamped this filing process to make it even easier than it was in 2024. And as word gets out, one thing that I would caution. Is if you do believe that an EMTALA violation has been committed, it is certainly your right to go to the CMS website and file the EMTALA violation. I would run it by your legal or someone in your health system that is knowledgeable on the nuances of EMTALA, because it is nuanced, and you may file what you believe to be is an EMTALA violation against another facility, only to find out that you've actually reported an EMTALA violation on yourself. So just be careful.
Yeah, and Todd brings up a good point. Both Todd and I have been through several EMTALA investigations, and we've been dragged into them. They are very, very painful, is an understatement. And as Todd had mentioned, you may be filing a complaint against a certain hospital, but they also may go through your facility and look for cases or find cases that relate to your facility in which you might be in violation. And that actually happened to our hospital many, many years ago. And it was kind of an unfortunate thing, but what turned out to be a reporting against another facility ended up being a violation at one of our sites.
Yep, absolutely.
And I think really the kind of simplest way to think about from a mental perspective is one, especially when you're not sure, do what's best for the patient, right? Yes, maybe the sending site from a transfer perspective is a little bit soft. Maybe they could take care of it there, but if they're really asking for help and they really can't take care of it, think about what is the best thing for the patient. If it's your family member, right? How would you want them to be taken care of? Number two, think about, transfer from the sending side is, look, if you can take care of this patient, don't just transfer out of convenience because you may run yourself into trouble. This is where gaining understanding the kind of fundamentals of EMTALA, and we'll talk a little bit more kind of as we go on the next couple of slides. And then if you're on the receiving side, it's very important to understand that, again, if you have capability and capacity to take a patient, right, don't decline the transfer because you may find yourself in violation of EMTALA.
Absolutely. And the very simple uh, the rules around EMTALA follow a very simple concept, which is they do not want a patient to get caught in the middle of a disagreement between physicians. And EMTALA doesn't care, and CMS doesn't care whether one physician or another feels like they've been, unfairly burdened. They don't care about the presence or absence of various insurance agreements or contracts or payers. What they want is to make sure that a patient is not caught in the middle of a disagreement. And the ruling for EMTALA will almost always go to what was best for the patient based on the information available at the time.
Yeah, and Todd, I think you bring up another good point, which is we oftentimes see either agreement or contracts being developed between hospitals and maybe physician groups, or between facilities or between physician groups. And just be careful that they are actually in compliance with EMTALA, and you don't find yourself potentially creating a position where you're going to be in violation of federal law.
Okay, so this is a little more detail, and again, I think the audience of this, most people are familiar with the basic tenets of EMTALA, and our goal here is to really dive deeper and talk about the nuances that you really need to understand in order to make the best decisions. So, number one is that, as we said, every patient that prevents within 250 yards of a building that houses an emergency department must receive a medical screening examination if that patient presents believing they have an emergency medical condition. If a patient shows up just saying, "Hey, where's my physical therapy appointment?" You are not under an obligation to provide them MSE. But if they show up believing that they have an acute issue, you do. You must log every patient that presents and offer them the medical screening examination. And I suspect every health system, mine included, has had situations where a well-meaning registration clerk or well-meaning triage nurse will tell a patient that we don't offer, that services here. So, I don't want to waste your time checking in and having you wait for something that we can't do. Why don't you go over to this other facility? And you can't do that. They must be registered, logged in, and it must be documented that they were offered a medical screening examination. If they refuse the medical screening examination, you must document that and document that they understood that we were offering a medical screening examination, that they declined, and that they have the capacity to do so. And you can understand why this exists, because let's just say that if a health system was trying to get around their EMTALA obligation to provide an MSE and stabilizing treatment for a particular patient, one way they could theoretically do that is to just never check the patient in, never register the patient. So there's no record of the patient having been there. Um, and I will tell you, having been through an investigation where a patient alleged this, they will go and review security cameras, and they will actually see if that patient physically came to the facility or not. And in one case, there was one where the patient did allege that. Well, um, the patient never came in the building, went to a wrong door, knocked on the wrong door, and ultimately the cameras proved that there was no violation, but that's how they went around, or that's how they evaluated it. The definition is that the medical screening examination should be sufficient to rule out an emergency medical condition. Well, as Bruce said, the medical screening examination is ongoing. So some places believe that you just triage a patient, and if their vitals are normal and their chief complaint is low acuity, then you've performed a medical screening examination, and your obligation is met. That is not true. The medical screening examination is of sufficient scope and duration to rule out an emergency medical condition. And as Bruce said, it is ongoing until either the patient can be discharged, the patient is admitted, or the patient is transferred. Until one of those three things has happened, then the MSE is ongoing. And an emergency medical condition is also vague. So it is any condition of which does or could create a risk to life or limb, um, including severe pain, and then labor. So there's no other specific definitions of EMC, and they want to leave it purposefully vague because they don't, when investigators don't want to be boxed into black and white definitions of what is and is not an emergency medical condition. And ultimately, the prudent layperson standard sort of applies here. So when in doubt, and as an emergency physician, Bruce, I'm sure you've told your residents this a million times. No matter how benign the initial appearance of a patient might be a triage, you know, uh, there can be a lot more going on. The MSE should include any testing or procedures necessary to rule out the EMC. It must be performed by a qualified medical personnel, which is typically going to be a licensed physician, PA, NP. Your bylaws can have exceptions for specific situations. L&D nurses for labor is a common one. And as Bruce mentioned, it must be insurance blind. So registration and insurance cannot delay the medical screening examination. It is okay to register and check in a patient before the medical screening examination has been performed, but it can't delay that MSE. And I think what most places do these days is they do sort of a quick registration when the patient first gets there, and then they do the full registration once the MSE is in progress or completed. If an emergency medical condition is detected, then the emergency department must provide stabilizing treatment within its capabilities to include the services of on-call specialists. And this is where specialist call comes in, and I'm sure Bruce will agree that specialists are often some of the areas where the most difficulties arise or complexities arise. And so understanding this is important. From EMTALA itself, failure of an on-call specialist to respond to a request from a hospital ED to provide screening assistance or stabilizing treatment can subject the physician and hospital to liability. So for this reason, most bylaws are very specific about what are required for specialist call. But specifically, the hospital must maintain a call list. That list must be in writing. The people on call must be listed by name. You can't have specialties. You can't have groups on call. It must be a specific person. All specialties that are represented at that hospital must be included as part of the call list. The extent of the coverage and the extent to which they are listed is based on staffing. And in the interpretive guidelines, they are very clear that there is no strict rule about how many providers are necessary until you're required to have 24/7 coverage, because it's all variable based on how busy the call is, et cetera. If you have one specialist that works at your hospital, you're not going to be expected to have 24/7 call coverage. You're going to be expected to have some reasonable call coverage that makes one person's life, manageable. If you have 6 specialists, you probably would be expected to maintain 24/7 call coverage for that. But again, they don't put a number on that because it all depends on how busy the call is. The need for a specialist is always in the judgment of the ED provider. And this is an area of contention, as you can imagine. But if the emergency physician believes that the specialist's help is needed in order to perform or assist with the medical screening examination and provide any stabilizing treatment, that's the end of it right there. The specialist is required to come into the ER and assist that ED physician. And again, most bylaws are going to address this. And so we talked about capability and capacity, and we'll get to capacity in a second. But what defines capability is very simply credentials/privileges. If a physician is privileged to manage a condition or perform a procedure, then the hospital is considered to have that capability. Now, there's an asterisk here because there are other factors that come into capabilities. So just because a physician is credentialed to do a certain procedure, if they need a surgical tech or they need an assistant or they need a particular piece of equipment or something, and that's not available, then you may not have the capability. So there are a lot of nuances, and I'll actually talk about that a little bit later because that can impact transfers. But as a basic rule, if the physician is privileged to do it, then you have the capability. I advise all of our physicians, our specialists, to review their clinical privileges and make sure they, in fact, do everything that's on there. If it's part of their core privileges, I know my health system is going to require them to get up to speed if that's not something they do. And if it's an elective procedure, an elective, a special privilege, and they don't really do it anymore, then we'll probably remove it so that that's not a requirement from an EMTALA standpoint.
And I think this is important where, especially as subspecialists take general call. So, for instance, you may have a general ortho on call for your emergency department, but if the person on call is a hip specialist or a hand specialist, and let's say it's the hip specialist and they haven't done a shoulder injury in 20 years, if they're covering general call, chances are their abilities and privileges, it probably has kind of what those requirements are that they're doing. And so even if they haven't done it, they're still going to be on the hook, right? And whether they stabilize as best they can and they call on the partners, whatever that arrangement looks on the back end, that's fine. But to understand that if they're on for general, they're going to be expected to take care of general type of things, even though they may be a sub.
So obligation number two, if unable to stabilize the emergency medical condition, then you must transfer a facility to a facility that can. There are some requirements in order to transfer a patient. First of all, the transfer must be medically indicated. Typically, it's going to be to a higher level of care, but the transferring physician must certify that the benefits of transfer outweigh the risks. And and that's not just um, that's a pretty complicated statement, which I'll talk about in a second. Um, but the patient must also consent to the transfer, request and or consent. Now, this is typically covered on every facility's EMTALA form. So when you're completing the EMTALA form for the transfer, the physician is going to be certifying that the benefits of transfer outweigh the risks. The patient is going to sign saying that they are consenting slash requesting to transfer. But that does need to be in writing, and that must accompany the patient to the new facility. But what's critical is that you cannot transfer a patient against their wishes. No matter how much your surgeon on call says, I want you to transfer this patient back to the facility where they had their surgery because I didn't do this patient's surgery, the patient has to consent to that. And if the patient says, no, I'm not going back there, I don't want to see that surgeon ever again, you cannot transfer that patient, and your surgeon is on the hook to manage that post-surgical complication, even if they didn't provide the surgery. Even if you do not have the ability to provide definitive stabilizing treatment, the hospital must still stabilize to their capability before transferring the patient. Now, if you know that you are not going to be able to provide definitive stabilizing treatment, then you're going to want to get that transfer going right away. But that doesn't mean that you just stop doing whatever is necessary. You are expected to provide whatever stabilizing treatment is necessary, including the assistance of that on-call specialist. However, you don't want to delay the transfer either. So, if you have a trauma patient, right, you're probably going to want to provide enough stabilizing treatment, whether it's a chest tube or intubation or whatever it is, in order to get that patient to the trauma center. So you don't want to delay the transfer, providing continuing stabilizing treatment, but you must continue to stabilize before you do transfer. And I think this is important. We're actually seeing this, unfortunately, in the state right now. Stability for EMTALA is not the same as a patient being stable to transfer. I think emergency physicians especially are very hesitant to indicate on an EMTALA form that a patient is unstable. But from an EMTALA perspective, you should only be transferring unstable patients. You should only be transferring a patient who has an unstabilized emergency medical condition because that's where EMTALA applies. If their emergency medical condition is stabilized, EMTALA no longer applies. You can still transfer the patient, but now it's just a routine transfer that isn't subject to EMTALA.
And
Any comments there, Bruce?
Yeah, Todd has a really great point, and I hear this, I think, confusion quite frequently. I think from a clinical perspective, when we hear stability, we think clinical stability, right? Their vital signs are stable. Oh, their vital signs are stable. Now, our EMTALA obligation ends. And as Todd had mentioned, that's not the definition that's used from a federal perspective, from EMTALA perspective. So it's important to understand the clinical definition of stability is not the EMTALA definition of stability. If you cut off somebody's hand, they've got an EMC, right? They're bleeding out, their hands detached, maybe be able to save that, right? Loss of limb. But you're stabilizing treatment from the setting site, even though you may not have the right capability, the specialist, the equipment to reattach the hand. You can still, right, stop the bleeding. Or if they lost a lot of blood, you may need blood transfusions, right? But even though their vital signs are quote unquote stable, right? They're not hypotensive. it doesn't mean your EMTALA obligation is ended. It's just that you've stabilized or you've given treatment as best you can or what you can give to that patient prior to transfer, but that EMC still exists. So EMTALA is still in play.
Definitely. And for example, our transfer center nurses, we have when we're requesting to transfer a patient, we're beginning the transfer with we have a request to transfer a patient with an unstabilized emergency medical condition. The patient is stable for transport. And so we're differentiating the EMTALA definition of stability and the clinical definition of stability to keep that EMTALA obligation intact. Um, a QFE point, a few key points here. The sending facility always determines the mode of transport. So the decision of how the patient is going to be transported when transferring a patient is the sole responsibility of the sending physician. They also bear that responsibility if something bad happens. You must use qualified personnel and equipment. Now, that is not defined as what qualified personnel and equipment means. It just means based on the individual circumstances. So if no personnel and no equipment are really required, can a patient go by personal vehicle? It's probably not recommended if you're transferring a patient, but sure, we all do it from time to time. And if the sending physician feels that that is safe, then they are allowed to do that because they also take the responsibility if something bad happens. I do hear occasionally where accepting physicians who are being asked to accept a patient in transfer want to try to decline a patient because they disagree with the mode of transport. They can make recommendations, but they can't decline to accept the transfer just because they disagree with the mode of transport. And then finally, any available records must accompany the patient. But I will caution, don't delay the transfer getting all the records together. If the patient needs to go, send them. Include whatever records are available at the time, and you can always fax whatever you don't have. So you can fax that and get it over there later. But you don't want to spend 30 minutes trying to get all the records together, waiting to and delaying the transfer. Third obligation, if the hospital has the capability and capacity to treat a patient, they must accept the transfers. So simply, capacity, do we have a bed or can we make a bed for that patient? ED beds don't count. So I'm sure, Bruce, you hear that also. We'll say we're at capacity, we can't accept the transfer. And they'll say, well, I just want to transfer ER to ER then. Well, that doesn't count. Like, we're not going to, if we have no inpatient capacity, we're probably also boarding a lot of patients in our ER. And so that doesn't count. You have to have the space to provide the definitive stabilizing treatment. But it's not just do you have a bed, it's can you make a bed? And investigators are going to look at how do you routinely handle overcapacity situations. So every hospital does. If you have a ICU, or I'm sorry, if you have a med surg patient that decompensates and needs to go to an ICU, and you shuffle patients around in order to create an ICU bed for that patient, well, then you're probably going to be expected to do that for transfers also. The way I think of it is how would you manage it if the patient was in your ER? If you would shuffle things around to create capacity for a patient that presents to the ER that needs that bed now, you need to do it with transfers also. So just because you're boarding in the ER doesn't mean that you can turn away the transfers. And then capability we talked about really comes down to privileges. I always say this, the capability at the sending facility doesn't matter. That is a common misunderstanding, I guess, is that if you believe that they have the capability to manage the patient and are sending it, you can't decline the transfer. You can accept it and report it, and it'll be investigated, but don't decline it unless the patient initiated the transfer. And so for our facility, if the sending physician says, we have the capacity, we have the capability, we're able to fully take care of this patient. The only reason we're calling the transfer is because the patient just wants to be transferred. Then you can say that's a lateral transfer, and if you want to, you can decline. But you have to be very careful, and we'll talk about that in a second. And then again, capability is defined by the specialist call schedule.
And I think the key is two wrongs don't make a right.
Yep. Yep, exactly. And what I tell people is, don't commit an EMTALA violation just because you think that the other person is committing an EMTALA violation. So, as a general rule, in a health system, physicians should only determine capability. Really, you shouldn't have physicians making decisions based on capacity because the physicians rarely have the big picture to understand, what your capacity and how you handle overcapacity situations is. That should be managed by a transfer center, by your bed control. You can't hold beds, you can't create crash beds. We still see some of our, nurses that have been around a while that want to hold a crash bed for a patient in the ER, and meanwhile your health system is declining transfers. You can't do that. Um, if the patient is stabilized and the emergency medical condition is resolved, or it's a true lateral transfer, meaning you know that they have the capability, and really the only reason for transferring is that the patient is requesting it, you can decline, but just be very careful. So you'd better be right that the emergency medical condition is stabilized or that it is a lateral transfer. Because when the investigators come in, they are going to look very closely. And again, the benefit of the doubt is almost always going to go to the physician who is at the patient's bedside. They don't want physicians who are making decisions over the phone and overruling a physician who is standing at the patient's bedside. Uh, Key point is distance doesn't matter unless it's outside the boundaries of the United States. So if a hospital in California wants to put a patient into an ambulance and transfer it to our hospital, and that patient's in an ER in that California hospital, we can't decline that transfer just because they're driving across the entire United States. We can certainly give them the advice that we think it's a terrible idea, and we think that you're taking unnecessary risks. And I encourage my physicians to go on the record, on the recorded line, that it is a bad idea. But you can't decline the transfer just because of that. And another common misconception is that EMTALA only applies to emergency department patients. It also applies to observation patients that were put into an observation status from the ED. Not just observation units, even if they're in a quote unquote inpatient bed, but in an observation status from the ED, then EMTALA still applies. Once they're admitted, once they're an inpatient, EMTALA doesn't apply anymore. So that's one of the things that I'll do with our physicians also is if we have a patient that's in our emergency department who is accepted for transfer to another facility, but we know that bed's not going to be available for 12 hours. We will encourage our hospitalists or our specialists to bring that patient into a regular hospital bed in an observation status because they're going to get better care for that 12, 18, 24-hour period than they are just sitting in the ED most of the time. And as long as we keep them in an observation status, EMTALA doesn't go away. That's usually their big fear is, oh, once I bring them in, EMTALA doesn't apply anymore and I'm going to be stuck with them. And that's not the case. Like we said, the sending physician always has the final say, but bears all the responsibility. All right, so let's review some specific case studies. These are cases that are either discussed in the interpretive guidelines or actual cases that have happened to Bruce or I, not to us personally, but as to our systems. So, case review one, a patient has surgery at Hospital A by Dr. Smith. On postoperative day number 4, the patient presents to Hospital B's emergency department with a non-life-threatening complication of that surgery, right? Super common scenario. Dr. Jones is on call at Hospital B in the same specialty. And the question is, what is Hospital B's obligation? Bruce, what do you think?
Yeah, so just going through step by step, you do the MSC, the medical screening exam, as they come to the emergency department. If you find an EMC, right, there's some sort of issue, complication that needs to be addressed. That's not simple as maybe a little bleeding. That can be done as an outpatient, right? You have an EMC, and now the hospital B is on the hook from an EMTALA obligation. So from a hospital B obligation, yeah, you're on the hook. You got a complication, you have an EMC, it is your responsibility to be able to handle this, even though, right, the surgery was done somewhere else, and no surgeon wants to take care of somebody else's postoperative complication.
Right. And so, what is Dr. Jones' obligation? Yeah, Dr. Jones' obligation is to assist in any way that the emergency department asks him or her to assist. Um, so now, what if Dr. Jones refuses because he or she says, I didn't do that surgery? What is, you want me to take this, what is Hospital B's emergency physician's responsibility? And then what is Dr. Smith and Hospital A's obligation to accept that back?
Yeah, so I think it's very important for the emergency physician to document that you consulted your surgeon on call and you asked him to see the patient, at the bedside. It gets a little bit uncomfortable, as you had mentioned before, but I think it's really important to be explicit, right, from an EMTALA obligation that you're consulting them and you want them to come see the patient at the bedside because you're concerned they have an EMC and you need help to resolve that or to stabilize that emergency medical condition. If they refuse, then what the emergency physician needs to do is to document it such that, look, I attempted to call, not in a non-inflammatory way, right? We don't want to create wars and charts, but in a very kind of bland, kind of a neutral and non-inflammatory way of what you did. And then you're going to proceed to transfer that patient to where they can get care for their emergency medical condition. And at that point, for hospital A, right, their expectation, obligation is to say yes, right? Even though this may be a EMTALA violation on hospital B's part, right? Two wrongs, again, don't matter.
And taking it a step further, Hospital A explicitly has an obligation to report Hospital B and Dr. Jones for the EMTALA obligation. This is the one scenario that EMTALA and the interpretive guidelines specifically discusses that if the hospital receives an inappropriate transfer, such as if a specialist refuses to respond, then Hospital B is required to report that that specialist refused to respond, and Hospital A is obligated to report that as a violation. What if the complication is life-threatening and the patient is unstable? I think that's pretty straightforward. Then, you're not going to, and when we say unstable, I mean clinically unstable, as in you can't put them into an ambulance. You can't put them into an ambulance. You gotta take care of them there.
All right, let's go case number two. So if a 30-year-old comes in with an abscess under the tongue, I think we've all seen this. You have ENT that consulted, reviewed the images from home, right? It doesn't come and see the patient, but from home, and said, you know what, it's not a surgical emergency. They can probably follow up as an outpatient. Just discharge them home, and we'll see them, in a couple of weeks, have them call the office. The ED doesn't feel comfortable with that. Patients transferred to a tertiary care center where they undergo emergency surgery and is there for 1 week for hospitalization. Todd, what are your thoughts about this case?
Yeah, so this is straightforward, right? The emergency physician requested the specialist assistance providing stabilizing treatment. The specialist said, no, it's fine. I looked at the images. You can send the patient home. Um, and so the ED physician does have to transfer that patient if they can't take care of them there. They are required to report that the ENT refused to come in, and they're required to report that to the accepting facility. I would say, the ED physician needs to be careful because if the specialist, says what they say, and the ED physician says, okay, yeah, sounds good. Then the ED physician could be on the hook also for not really formally requesting that ENT comes in.
And I think it's an important point that you bring up, which is be explicit, right? Say, hey, I don't agree with that recommendation. I think you need to come in and see the patient and be very explicit about what you want.
Okay, third case, 46-year-old uninsured person has a jaw abscess, presents to the ER. I feel we're picking on ENT here, aren't we? No on-call
Or ENT
ENT.
folks.
So they have no on-call ENT. The patient is transferred to an academic hospital, which is further in distance from an affiliated hospital of the ED that the patient is in that has an ENT. Patient ends up having surgery and a 2-week hospital stay, and that academic hospital says, "Hey, we think this was an EMTALA violation. You bypassed two of your own hospitals to send the patient to us." Is that a violation?
Yeah, so there's no violation there. And as Todd had mentioned earlier, distance does not come into account when it comes to EMTALA. Now, there are other issues, right? Maybe medical malpractice if you're trying to send something that's 100 miles away versus maybe 2 miles away for something that's fairly urgent or emergent. But from an EMTALA perspective, it's not an issue.
Yep. If you were found to have if the sending physician were found to have inappropriately delayed the treatment of that patient by sending them further away, then they're definitely on the hook. But that's their choice and their responsibility.
Case number four. So 54-year-old patient comes in with a head bleed and needing surgery. The setting hospital doesn't have neurosurgery, just like many of our hospitals out in the community. The on-call neurosurgeon at the hospital within the health system says, thanks, but no thanks. But you know what? There's closer hospitals that can go to. Why don't you transfer there? Even if it's a non-affiliated hospital outside the health system, that's okay. But just you should go somewhere closer for better patient care. Todd, what are your thoughts from an EMTALA perspective?
Yeah, so it really depends. If the neurosurgeon makes the recommendation to go to the closer hospital, but says, hey, I'll accept that patient, but my recommendation is they go closer, then they're okay. But if they say, nope, I'm not accepting that transfer because they need to go to a closer facility, then that is an EMTALA violation because again, it's the decision of the sending physician, not the decision of the specialist. So I tell my specialists, start off every every time you're being asked to accept a transfer. If you have the capability to care for that patient, start off every discussion with, I am happy to accept that patient and transfer. However, my recommendation is fill in the blank. And they can make that recommendation. They're always worried that they're going to be, that they're medical legally liable if they accept the patient when the patient should theoretically go to a closer hospital. And I've discussed it with our attorneys. We've repeatedly stressed that you're not on the hook for accepting that patient. It's the sending physician that is on the hook. You are on the hook for the advice you give, but don't decline the patient.
Yeah, and again, the medical legal right aspect of it is going to be different than the EMTALA aspect and
Correct.
obligation.
Yep. All right. Next case. So 32-year-old patient presents for a voluntary psych admission for suicidal ideations. The patient is medically stable, medically cleared, no active suicidal ideations at the time. The patient is accompanied by their spouse, who is a nurse. The patient is accepted to a mental health hospital, but there's going to be a 3-hour wait for medical transport. And the patient and spouse say, you know what, we don't want to wait. We're going to drive straight there. Um, but the mental health hospital says, nope, we're going to decline this transfer because we think that's too dangerous. What happens if the patient, opens the car door at an intersection and dives out? So we're not going to accept the patient because we don't want to be on the.
Yeah, so a tough one and one that we actually unfortunately see not uncommonly, right? How long does it take transport to come? It could be sometimes it's quick, sometimes it could take hours, and people don't like to wait. But so two things, and this is what we discussed here earlier. One is the sending site, right, gets to determine the mode of transport, and the receiving site, right, can't have conditions of acceptance, including condition of acceptance based on what type of transport they do. So the receiving hospital, in this case, potentially was going to be in violation of EMTALA. Now, from a sending perspective, it is required to send, appropriate medical personnel and equipment that's needed for transports. It's often left pretty vague in terms of what that actually entails. I think, though, most people would say, though, if you're transferring somebody, especially for specialty care that you don't have to continue on to treat the EMC, that probably should go by officially by some sort of medical transport. And if you do it, or if they do go by private vehicle or not by medical transports, to have some sort of sign against medical advice. But be very careful of doing that because if something were to happen from a medical legal perspective, you could be on the hook, as well as from an EMTALA perspective.
Yeah,
Todd,
and so what we did is, we use Epic, but I would imagine you can do this within most electronic medical records, and our EMTALA form is built into Epic, and so we built a component in there where if the physician selects mode of transport, POV, personal vehicle, it opens up a new set of criteria which the physician must certify that they discuss with the patient that medical transport was recommended, that we were arranging medical transport, that the patient or the responsible party is declining medical transport, that they have the capacity to do so, and that they understand the risks of declining medical transport, that they're going to drive straight there, et cetera. So all of those things are things that the physician must certify that they discuss with the patient. And then the patient, when they sign, must sign or the responsible party must sign certifying that has been reviewed with them. And so really it's an AMA. It's an AMA form built within Epic for personal vehicle transport of transfers.
Yeah,
All right.
and I do
Go.
physician and EMTALA reviews kind of on the side every now and then. And unfortunately, this comes up not infrequently is the transport where risk and benefits documented by the physician and notified to the patient. And especially people who want to go by private vehicle. We do the same thing in our health system. It's by AMA. So there's kind of making sure you document very clearly, right, that you are willing to do this, but they are declining that, right? And so they're kind of going against medical advice. We're still going to treat them like we normally do and still facilitate the transfer, but from a appropriateness, from a transport perspective, right, they're going to leave AMA, and we're going to document those risks and benefits very clearly in our chart.
All right. And last case,
Yeah.
60-year-old patient diagnosed with multiple finger amputations at an ED with no hand surgery. The ED physician requests transfer to a tertiary care center that has a hand surgeon. The accepting facility asks if the patient is stable, and the ED physician says yes. The accepting facility then says, "Well, we're gonna perform an insurance review," and declines to accept because they are currently out of network with that patient's insurance provider. Is that an EMTALA violation?
Yeah, unfortunately, it is, right? So, this goes back to the definition of stability. We oftentimes think stability from a clinical perspective, right? Are their vital signs are stable? But in this setting, this person has an emergency medical condition that has not been resolved, right? The fingers are cut off. They potentially could be reattached, right? Replanted. You have a certain amount of time. And so the patient is unstable or has not been stabilized from their emergency medical condition, even though clinically they may be stable. So EMTALA is in play. And as we talked about earlier in the beginning of this talk, right, you cannot use insurance, right? You cannot use payment of method or method of payment, right, as a screening tool, whether to accept or decline a case such as this.
All right. Well, I think we could do this all day. I love talking this. I think that's our last case. Any closing thoughts, Bruce?
Yeah, I think it's really tricky sometimes and frustrating to be, especially from a transfer perspective, either the sending or receiving side. I think from a receiving side, it's really important to understand, like, if you have the capability of taking the patient, it's always safer to say yes and then sort out the details later on, even if you know that the sending site may be in potential violation of TALA. Have a plan or working with your executives, working with risk and legal in terms of how do you report, right? How do we kind of work together so that we all can be on the same page and we're not running into these issues, especially after the fact.
Dr. Parker, any final thoughts?
No. I just go back to, do what's best for the patient and don't put the patient in the middle of a disagreement between physicians or facilities.
Good in cap there. And with that, I want to thank both of you, Doctors Lowe and Parker, our ex-presidents of VACEP, for their time. And we thank you all for joining us. We hope you walked away with a new understanding of EMTALA and transfer protocols. Thank you again.